Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello everyone, my name is Hiddo Heerspink. I'm a clinical trialist affiliated with the University Medical Center Groningen in the Netherlands. Welcome to this program titled Data Blitz. What's new in CKD management for type 1 diabetes? Joining me today is Professor Chantal Mathieu. She's Professor of Medicine at the Catholic University in Leuven in Belgium. Welcome, Chantal.
Hello, Hiddo.
Today we will be reviewing the status of type 1 diabetes, guideline recommendations for chronic kidney disease and type 1 diabetes, the mechanism of action of non-steroidal mineralocorticoid receptor antagonists, and clinical data with agents in type 1 diabetes with chronic kidney disease. And then at the end, we will discuss the implications of all this new data and a future outlook. So Chantal, can you give us an update on the status of type 1 diabetes today?
Well, where do I start? We're living in the most exciting times when it comes to type 1 diabetes because our insights in the pathophysiology of this disease now open up a new path where we're even thinking of preventing and curing type 1 diabetes. Think of the new disease-modifying therapies that are coming our way, therapies that are affecting the immune system in this autoimmune disease, trying to protect the beta cell, and also the whole islet transplantation field now advancing rapidly with the stem cell technology coming to the rescue as a source of new beta cells. But for those who live with type 1 diabetes now, we also have seen a revolution with the advent of novel technologies. Indeed, the advent of continuous glucose monitoring, the sensors, has dramatically changed the life of those living with type 1 diabetes. We have now a continuous view of glucose values. We have alerts of impending hypoglycemia, for instance. But the real revolution actually came when these CGMs could be connected with pumps and now create automated insulin delivery systems. And these automated insulin delivery systems are rapidly becoming the standard of care in many countries. These automated insulin delivery systems improve hemoglobin A1C, give more stable glucose control, and prevent hypoglycemia risk. So AIDs have really changed the face of type 1 diabetes nowadays. However, type 1 diabetes still causes loss of life years when we look at the life expectancy of those living with type 1 diabetes compared to those not having type 1 diabetes. And this is due to acute complications. I already alluded to hypoglycemia, for instance. Unfortunately, also diabetic ketoacidosis is still happening. But it is mainly chronic complications that will affect life expectancy. There is the chronic complications, the microvascular ones, the retinopathy, there's renal disease, there's neuropathy, and there's cardiovascular disease, putting people with type 1 diabetes, for instance, at the highest risk of heart failure. But it is when you look at the differential between life expectancy in people with type 1 diabetes and those without type 1 diabetes, it is mainly renal disease making the difference. It is mainly those living with chronic kidney disease, having macroalbuminuria, having end-stage renal disease, needing kidney replacement therapy, for instance, that affect this difference in life expectancy between people with type 1 diabetes and those without. So our guidelines have really not only addressed how we should achieve good glycemic control, but they also give us guidance on how to specifically address renal disease in diabetes. So, Hido, can you dwell on these guidelines and what they tell us on how to address renal disease in people living with diabetes and type 1 diabetes in particular?
What an enormous progress. It's unbelievable indeed. And so the guidelines have also evolved because all these new clinical data that came to us in the last couple of years have now been implemented in clinical guidelines. So when we look, for example, at the Kidney Disease Improving Global Outcome Guideline, the International Kidney Guideline, and we specifically focus on the Diabetic Kidney Disease Guideline of that initiative, we see that the kidney disease guideline for type 2 diabetes and chronic kidney disease recommends lifestyle for everyone. And this is the cornerstone. If we don't change our lifestyle, if we are not adhering to healthy diets, we are not making progress. But we know that it is difficult, and we know that many patients also require medications. So for type 2 diabetes, we have seen SGLT2 inhibitors. They are implemented and they are used and recommended for treatment of chronic kidney disease in type 2 diabetes, and we'll be discussing their role in type 1 diabetes. Renin-angiotensin system is, of course, the mainstay for the management of chronic kidney disease, and this is recommended by the guidelines. But renin-angiotensin system inhibition is good for many patients, but there are still patients with high blood pressure, high albuminuria, and so for those with resistant hypertension, the role of mineralocorticoid receptor antagonists become more and more important. They are recommended now by the guideline as a mean to slow the progression of chronic kidney disease to optimize blood pressure control. And then for those with high cardiovascular risk, we can also use statins, and they can be used both in type 1 as well as in type 2 diabetes.
Yeah, so a lot of emphasis in these KDIGO guidelines, for instance, Hido, on lifestyle, on renin-angiotensin system interference, and that is true for type 1 and type 2 diabetes, for all types of diabetes. But then indeed, in type 2 diabetes, we now have a lot of evidence on specific agents like the SGLT2 inhibitors and also the GLP-based therapies. And yet another class of agents coming to the forefront, and that is the mineralocorticoid receptor antagonist, with a new class of interesting tools now coming our way, the non-steroidal MRAs. And they're not included yet in the guidelines, but what is the rationale, Hido, for using them in people living with diabetes and type 1 diabetes in particular?
Yeah, we have learned, of course, and we know that for many years that aldosterone plays a very important role in the pathophysiology of chronic kidney disease, both in diabetes as well as in non-diabetes. Aldosterone is upregulated in the setting of hyperglycemia, but can also be upregulated in the setting of high salt diet or oxidative stress. As soon as aldosterone binds to its receptor, it causes overactivation of the aldosterone receptor, and that causes an array of downstream effects: sodium retention, inflammation, fibrosis, and in the kidney, apoptosis, podocyte damage, tubular interstitial damage, albuminuria, and all these effects together lead to a decreased nephron functionality. So if we can block the receptor with specific receptor antagonists, we can block the downstream effects and thus intervene in the pathophysiology of chronic kidney disease. Of course, we had those drugs, spironolactone and eplerenone, the steroidal MRAs, but they can often not be used in people with chronic kidney disease because these drugs cause hyperkalemia, and that's often a reason why patients don't tolerate these drugs. Finerenone is a so-called non-steroidal mineralocorticoid receptor antagonist. It has a different chemical structure, and with that a different binding characteristic to the aldosterone receptor. In experimental studies, it has shown differential effects on sodium and potassium excretion, leading to a reduced risk of hyperkalemia, at least in the experimental work. And thus, this may be of interest, in particular for people with chronic kidney disease who could not tolerate spironolactone or eplerenone.
Yep, and that's what the trials, for instance, in type 2 diabetes have demonstrated. But we're now entering the next phase because you have presented some time ago now the FINE-1 trial at the American Society of Nephrology meeting, where you have presented the first ever results on finerenone in type 1 diabetes. So can you elaborate on the novelty of this trial and share with us the main results?
Yes, it's indeed my pleasure to talk about the FINE-1 clinical trial. And the trial was designed after we had seen the results of finerenone in type 2 diabetes. Two large clinical trials in type 2 diabetes were performed, Figaro and Fidelio. And when the two trials were combined in a pooled database, which is called Fidelity, it was demonstrated that finerenone reduced the risk of a clinical and kidney endpoint of 40% GFR decline kidney failure by 21%. Finerenone also reduced albuminuria, the surrogate outcome, by 32%. And subsequent calculations demonstrated that 87% of the benefit of finerenone on the clinical kidney endpoint was actually explained by the reduction in albuminuria. So we could now use albuminuria as a marker to translate the evidence from type 2 diabetes, where the effects on the clinical endpoint were already proven, to type 1 diabetes by just showing that finerenone reduces albuminuria in type 1 diabetes and chronic kidney disease. As such, albuminuria is used as a so-called bridging biomarker to translate evidence from one population to another. This was not an idea that came from the investigators. Actually, the Food and Drug Administration in the United States suggested that we use albuminuria as a bridging biomarker. And so we designed a clinical trial of finerenone in type 1 diabetes and chronic kidney disease. The trial duration was 6 months, and participants were randomized to finerenone 20 mg per day or placebo in a 1-to-1 ratio. After 6 months of treatment, patients proceeded into a 1-month washout period to assess the off-drug effects. Participants were living with type 1 diabetes and chronic kidney disease, defined as a GFR between 20 and 90 mL per minute and an albuminuria level between 200 and 5,000 milligrams per gram creatinine. So these patients were at risk of progression. Patients with a potassium level above 4.8 millimole per liter could not participate, and SGLT2 inhibitors and GLP-1 receptor agonists were not allowed because the guidelines do not recommend these medications for type 1 diabetes. The trial was a global clinical trial conducted in 9 countries at 82 clinical centers. And so this is the first global clinical trial in type 1 diabetes and chronic kidney disease. Now, the primary endpoint was the change in albuminuria from baseline over the 6 months treatment. So we took all the albuminuria measures over time into account, and we calculated the so-called average effect. The secondary endpoints were safety, in particular hyperkalemia. We enrolled 242 participants, of whom 120 were randomized to finerenone and 122 to placebo. The mean age was around 50 years, and about 3/4 of the population was male. The majority were white or Asian. The BMI was around the 27 kilogram per square meter, and the mean eGFR at baseline was 59 mils per minute. The median UACR was around 550 milligram per gram, again indicating that these patients were at high risk of progression towards kidney failure because of the high albuminuria levels and the lower GFR. The mean duration of diabetes was 32 years, and nearly all participants except 3 patients were using an ACE inhibitor or angiotensin receptor blocker, so they were treated according to current standard of care. Now, the results demonstrated that over time, indeed, finerenone reduced albuminuria, and we can see the albuminuria graph where we see that after 3 months of treatment, there was a difference between placebo and finerenone of 21%, and this increased to 28% at the end of the 6 months of follow-up. Now, when the patients discontinued their medication, either finerenone or placebo, we saw an increase during the 1 month washout period in the finerenone group compared to no change in the placebo group. So now when we take the measures of albuminuria over time into account, relative to placebo, finerenone reduced albuminuria by 25%, and that effect was highly statistically significant. Is it clinically meaningful? Yes, this is a clinically meaningful effect. We know from large meta-analyses of clinical trials that a 25% reduction in albuminuria gives us more than 98% confidence that the drug will also reduce the risk of kidney failure. And so we have a new drug. The trial was positive. It met its primary endpoint, and thus we have a new intervention that reduces albuminuria in a setting where we know that with this drug, that will also translate into a reduction in kidney failure. But when we talk about efficacy, we should always balance the efficacy with the safety data. So when we looked at the safety, finerenone was well tolerated in this population. The proportion of patients that reported an adverse event was similar between the placebo group and the finerenone group. Also, when we looked at serious adverse events that require hospitalization or prolonged hospitalizations, there were no differences between finerenone and placebo. As expected, with any drug that intervenes in the renin-angiotensin system, we saw more hyperkalemia events. There were 10% of patients, 12 patients in total, that reported hyperkalemia in the finerenone group versus 3.3 or 4 patients in the placebo group. But importantly, the clinical impact of these hyperkalemia events were low because there were very few patients that discontinued the study medication due to hyperkalemia, and none of the hyperkalemia events led to death. So although there were more hyperkalemia events reported, their clinical impact is very low. So we have a new drug, a non-steroidal mineralocorticoid receptor antagonist for the treatment of chronic kidney disease in type 1 diabetes. But Chantal, do we also have other data on renal disease and its modification in type 1 diabetes coming from post-hoc analyses from large clinical trials, namely the trials on SGLT2 inhibitors in type 2 diabetes, as well as real-world evidence? And although the SGLT2 inhibitors are not indicated for use in type 1 diabetes, in these trials, at least in type 2 diabetes and non-diabetic patients, SGLT2 inhibitors are very effective. In type 1 diabetes, as I mentioned, they are not approved for use, but we do have quite a few data suggesting nephroprotection in type 1 diabetes.
Indeed, as you hinted, Hido, we are entering a new phase now with finerenone as a drug really affecting kidney disease in people with type 1 diabetes, and also showing a very interesting safety profile. With the SGLT2 inhibitors, we never made it to the label in people with type 1 diabetes because of the safety profile. There have been quite big programs studying dapagliflozin, empagliflozin, even the SGLT2, SGLT1 inhibitors, sotagliflozin, in people with type 1 diabetes. And they all showed a good hemoglobin A1C lowering, some lowering of the weight, more stable glucose control, but unfortunately, we did see the side effects. We saw the side effects that we knew from type 2 diabetes, namely genital infections, but there was the feared side effect of diabetic ketoacidosis increase. And that was present throughout all the programs, 2 to 4% in a dose dependent way. There were some precipitating factors, like, for instance, people on pumps. But I just told you at the beginning of our discussion that now more and more people are using automated insulin delivery systems. So for the moment, we do not have any of our SGLT2 inhibitors that are in our clinical hands on label. But still, let me share with you some interesting observations in those big programs with the SGLT2 inhibitors in people with type 1 diabetes, because some of them did show effects on albuminuria. Here, for instance, the data coming from the studies with dapagliflozin, the DEPICT program, and here published by Professor Group, you can see the effect in a 52-week study. In the colored lines for dapagliflozin, you see a decrease in albuminuria for people treated with dapagliflozin. And on the other hand, you can also see the effect on EGFR. Again, small numbers, small groups, but you see the same trend, namely the decrease in EGFR in the beginning and then the crossing of the lines as the trials progress. Here, the data with sotagliflozin in the in tandem trials, again, the same hint of lowering of albuminuria and the effect on EGFR. Again, this was only observations during 6 months. But we also have data on empagliflozin, also in the EASE trial. We saw the same effects on albuminuria, but it was really the EMPA-KIDNEY trial where we had high hopes of seeing bigger effects in people with type 1 diabetes. Because the EMPA-KIDNEY trial was a study specifically done in individuals with renal disease, so with albuminuria, with EGFR impairment. And here people originally with type 2 diabetes and without type 2 diabetes, but also with type 1 diabetes were included. As the trial went on, because empagliflozin didn't get the label for type 1 diabetes, the inclusion of people with type 1 diabetes was stopped, but it does give us the opportunity to look at these people with type 1 diabetes, and they behaved exactly the same as those with type 2 diabetes or without diabetes. Namely, there was a decrease in the renal endpoints. There was a decrease in albuminuria. There was the same effect on EGFR. So again, a hint that these SGLT2 inhibitors indeed protect the kidney in people with type 1 diabetes, just like in people with type 2 or without diabetes for that matter. But again, when looking specifically at the side effects, you can see that, again, ketoacidosis was happening. And as you can imagine, it was mainly in the people with type 1 diabetes that these increased risk of DKA was happening. And so this is really an issue. Therefore, no label for the SGLT2 inhibitors for the moment, but we as clinicians are using them in people with type 1 diabetes because they do affect hemoglobin A1C and weight and a more stable glucose control. And we know that there is this effect on renal disease, and we hope that there's also this effect on heart failure. Because remember, people with type 1 diabetes are at the highest risk of heart failure. And so we're using them in the real world. And here's some data from our own center in Leuven, together with a center in Valencia in Spain, where we looked at these effects of the SGLT2 inhibitors in type 1 diabetes. Same effect on hemoglobin A1C, on weight. And interestingly, when we looked at those individuals who had an increase in albuminuria, you saw the same trend of effect of protection of the kidney, with decrease in albuminuria and the same effect on EGFR, the same curve on EGFR. Unfortunately, we confirmed also the adverse safety profile of these agents, namely genital infections, we can deal with that, but also even in our centers with a lot of education on prevention of DKA, we did see the increased risk of DKA in about the same numbers as what we saw in the big programs that I just presented to you. But we have now an evolution in technology. We have the continuous ketone monitors also coming our way. So we're still very hopeful that these SGLT2 and eventually the combined SGLT1/2 inhibitors may come in our hands as clinicians. And we're so excited, Hido, that there's actually a big trial happening now with sotagliflozin. So can you discuss this trial for us?
Yes, indeed. Next to the FARM-1 clinical trial that I just presented, we also have a clinical trial ongoing with an SGLT1 inhibitor, sotagliflozin. And the sugar and salt study will assess the effect of sotagliflozin compared to placebo on the rate of kidney function decline, eGFR decline, over time. So in this clinical trial, patients with type 1 diabetes and chronic kidney disease with a GFR between 20 and 60 and high albuminuria will be randomized 1-to-1 to sotagliflozin or placebo. In contrast to the FIND-1 trial, these patients will be followed for 3 years to assess the longer-term effects of sotagliflozin on the rate of GFR decline. And so this trial will give us important data about the effects of SGLT2 inhibitors in people with type 1 diabetes and chronic kidney disease, but perhaps even more importantly, will also assess the safety of SGLT2 inhibitors in type 1 diabetes, because that these drugs work and are effective, we know, but the question is how to optimally use them in type 1 diabetes. And as you said, Chantal, maybe the continuous ketone monitors that are currently in development will help us to mitigate that risk of diabetic ketoacidosis. So we've seen new data also for type 1 diabetes and chronic kidney disease. We have left these patients behind in the last couple of years, but I'm extremely happy that we now have new data, new clinical trials, new drugs for these patients. So what does this mean for clinical practice, Chantal?
Oh, as a clinician, I'm very excited, Hido. As said, we are entering a new era with hope for those who are in the early preclinical stages of type 1 diabetes, that through screening programs we can detect them. Through use of disease-modifying therapies, we can delay the progress to clinical stage 3 type 1 diabetes. Hopefully one day the cell therapies will also allow us to give beta cell replacement to those living with type 1. But already now we have the new technologies. But renal disease remains the big reason why in those living with type 1 diabetes, there's still this differential in life expectancy. And so having new tools in our hands, especially a drug like finerenone with a side effect profile we can deal with, namely the hyperkalemia, that is a thing we can deal with. We know how to detect it. We know how to monitor. So in interesting times to have a new agent like finerenone. And on the other hand, really looking forward to sugar and salt. And again, the entry of the continuous ketone monitors in our clinical hands to really be able to use SGLT2 inhibitors in people with type 1 diabetes too. So finally, I would say, Hido, finally we will have tools in our hands to arrest the progression of renal disease.
Yes, indeed. I think you've summarized it beautifully, Chantal. And for me, it's very important that we now start to identify the patients, screen for chronic kidney disease, screen for albuminuria. You have the tools in your hand when you identify somebody to treat them with safe and effective medications. So all in all, I could say that we now have hope for people with type 1 diabetes when it comes to slowing the progression of kidney disease. Chantal, would like to thank you very much for this great discussion, for the insights you have given us. And I would also like to thank you, audience, for participating in this activity. Please continue to answer the questions that follow this presentation and also complete the evaluation so that we can learn to make these sessions even better in the future. Thank you very much for listening.
This program was presented by Medscape Education Global.